guys, it's Ava, and my presentation is on the role of vitamin C infusions for patients with sepsis. Okay, so to give the presentation a little structure, I'm going to start by giving a brief overview of sepsis and vitamin C, then discuss the main meta-analysis, and then we'll finish with future implications. So to give a little overview of sepsis in general, in intensive care units, severe sepsis remains the primary cause of death and is responsible for about 9.3% of all annual deaths in the United States. Among industrialized nations, sepsis ranks as the third leading cause of mortality, with death rates comparable to those from acute heart attacks. Clinically, sepsis is identified by the presence of systemic immune response symptoms triggered by an infection. Conditions such as infection, trauma, ischemia, and major injury play a role in the development of severe sepsis, which is marked by the excessive release of pro-inflammatory cytokines. So looking into vitamin C and its role in a possible sepsis treatment, vitamin C, also called ascorbic acid, is an essential micronutrient and one of the body's most powerful water-soluble antioxidants. In theory, vitamin C may help reduce the inflammatory response associated with sepsis. Its low cost, wide accessibility, and generally safe side effect profile, with diarrhea being the main symptom of a toxicity, make it a strong option as an additional therapy in sepsis care. However, its use remains controversial because there's not enough strong evidence to support its effectiveness, leading me to review the main meta-analysis in this presentation. The primary meta-analysis in this presentation is called The Role and Efficiency of Vitamin C in Sepsis, a Systemic Review and Meta-Analysis, published by Mohammed et al. In July of 2022. The study pulled information from the Central Cochrane Registry of Clinical Trials, NBOS, and PubMed. For eligibility criteria to be included in the review, studies were required to be randomized control trials that evaluated high-dose vitamin C administration in septic patients, with standard care serving as the control. All patients had to be over 18 years of age, and articles had to be available in English, regardless of publication date or status. All studies that did not meet these criteria were excluded. Alrighty, for data extraction, the Cochrane collaborative tool was used to categorize the risk of bias as low, uncertain, or high. The grade system was used to evaluate the quality of evidence, with each outcome being rated for quality, reducing the level of evidence for risk of bias, inconsistency, indirectedness, and imprecision. A pre-specified extraction table was used to collect data from published trials and their tables and appendices. A second author independently reviewed the extracted information to ensure accuracy. Extracted variables included number of patients, mortality, sequential organ failure assessment, also known as SOFA score, hospital length of stay, intensive care unit or ICU length of stay, and days on vasopressors. The primary outcome was short-term mortality. Secondary outcomes included change in SOFA score, ICU length of stay, duration of vasopressor requirement, and hospital length of stay. The meta-analysis was conducted using comprehensive meta-analysis software V3. Main differences were calculated for continuous variables, while odd ratios were used for categorical variables. For studies reporting medians and interquartile ranges, data were assessed for skewness and normality. Means and standard deviation were imputed when appropriate. Standard errors were derived from 95% confidence intervals, and p-values less than 0.05 were considered statistically significant. A random effects model was applied, and heterogeneity was evaluated using the I-squared statistic. Moving on to results, a total of 2,176 articles were initially identified. After removing duplicates, only 1,930 articles remained. Following the first screening, 72 full-text articles were assessed. Of these, the final meta-analysis included 23 randomized controlled trials on vitamin C and sepsis, with a total of 2,712 patients. Retrospective studies were excluded. To break the included trials up, 20 studies used intravenous vitamin C, while 3 used enteral, being oral or tube administration, and some studies gave vitamin C alone, which I will later refer to as monotherapy, while others combined it with thiamine and hydrocortisone. Okay, so evidence summarized in Table 2 suggests that vitamin C may provide modest benefits in patients with sepsis, particularly when administered as a monotherapy. Patients who received vitamin C had significantly lower overall mortality compared with standard care, with approximately 6 fewer deaths per 100 patients. The p-value for this statistic is 0.016, making it statistically significant. Intravenous administration appeared more effective than enteral routes, likely due to absorption limitations in critically ill patients. Monotherapy, as I mentioned earlier, showed the strongest mortality benefit with around 15 fewer deaths per 100, whereas combination regimens with agents such as thiamine and hydrocortisone did not demonstrate a significant mortality advantage. Table 3 presents secondary outcomes, showing that vitamin C may slightly improve organ function as indicated by a small reduction of SOFA score and may reduce the duration of vasopressor use and ICU length of stay. However, the certainty of findings for secondary outcomes remains low to very low. For the possible mechanisms, although the exact mechanism contributing to these results is not fully understood, theories include vitamin C's ability to reduce inflammation and oxidative stress, regulate cytokines by decreasing harmful ones such as TNF-alpha and IL-6, while increasing protective ones like IL-1, enhance the function of immune cells, including macrophages, lymphocytes, and neutrophils, and mediate neutrophil extracellular trap or NET formation, which helps prevent tissue damage. For limitations, heterogeneity remains a major challenge due to the inclusion of studies involving diverse patient populations at varying stages of disease. There's no standard definition of a, quote, high dose of vitamin C, and limited guidance exists regarding optimal dosing, frequency, or administration route. Some studies administered vitamin C enterally, which in septic patients can lead to unpredictable absorption and potential drug-drug interactions. Many studies lacked complete reporting of patient characteristics, age groups, and causes of mortality, reducing overall confidence in the evidence. Several studies presented outcomes as medians, which often deviated substantially from a normal distribution and were therefore excluded from analysis. This limited the sample size. Lastly, variations in drug combinations, ICU protocols, and hospital policies further contributed to heterogeneity and reduced the certainty of results. For the strengths, past meta-analyses have showed mixed results due to differences in patient populations, use of vitamin C alone versus in combination therapy, ICU protocols, and disease severity. Therefore, some guidelines, like Surviving Sepsis guidelines, do not recommend routine IV vitamin C because of earlier limited evidence. However, leading to the strengths section, the Mohammed et al. Study added updated evidence showing consistent benefits in mortality and SOFA score, strengthening the case for vitamin C use in sepsis. While the Mohammed et al. Study did have similar limitations resulting from differences in patient population, it had a larger patient population, making it more significant. The culmination of evidence suggests that vitamin C may be a useful therapy in addition to standard sepsis treatment. However, questions regarding the optimal dose, route of administration, and timing of vitamin C therapy are still unanswered. To address these gaps, there's a strong need for a large, well-designed, multi-center randomized controlled trial with sufficient statistical power to clarify its true clinical effectiveness. Moving on to the most applicable part for us of implications for dietetics and nutrition. Dietitians working in the ICU setting should be aware of the emerging evidence regarding high-dose vitamin C supplementation and sepsis management, particularly when used alongside standard medical theories. Giving the enteral absorption of vitamin C can be unreliable in clinically ill patients. Nutrition professionals, such as dietitians, may need to collaborate with the medical team to determine whether IV administration is more effective than oral or enteral routes. Patients with sepsis often present with micronutrient deficiencies due to increased metabolic demands, oxidative stress, and reduced intake, making the monitoring and correction of vitamin C status and potentially other antioxidants an important component of care within the dietitian's scope of practice. Since vitamin C may be administered alone or as part of a combination therapy with agents like thiamine and hydrocortisone, as I've mentioned before, dietitians should participate in interdisciplinary discussions to ensure nutrition support aligns with the overall medical management. Additionally, dietetics professionals have opportunities to contribute to future research by helping design clinical trials that evaluate nutrition-related outcomes such as inflammation, oxidative stress, healing, and long-term recovery. This new possibility of using vitamin C as a therapy for sepsis patients really gives dietitians the chance to make meaningful differences in a patient's overall care. Lastly, here are my sources. Thank you guys for listening.